Dr. Sehar from DENTABEST, your best online mentor for the preparation of INBDE ADAT and AFK exam. Today, students, I have taken a very important topic for your exam, a staging and grading of the periodontal diseases as per the latest classification we have from American Association of Periodontists. Let us quickly review the topic here. The periodontitis classification, student, is based on the stage of the periodontitis, extent and the grade. So the stage includes the severity and the complexity of the case, one stage per patient based on the most severe sites, while the extent is describing the extent of the disease, whether the periodontitis is localized, generalized, like in molar incisor pattern, and the grade is the rate of disease progression and the risk for any future deterioration. Only one grade per patient. So the screening of the patient, full mouth probing depth you take, full mouth radiograph, any missing teeth due to periodontitis, moderate to severe periodontitis or mild to moderate periodontitis will typically be either stage 1 or stage 2. Severe to very severe periodontitis will typically be either stage 3 or stage 4. The periodontitis staging is designed to give information about the whole mouth relative to the severity and the complexity of the patient's periodontal status. The stage will also inform the clinician of the initial difficulty and the complexity of the required treatment. So staging describes the severity and complexity of each case, and severity is measured by CAL, that is clinical attachment loss, radiographic bone loss, that is RBL in percentage, and the tooth loss caused by periodontitis. The complexity of managing the case is measured by probing depth, furcation involvement, type of bone loss, vertical or horizontal, need for complex rehabilitation, masticatory dysfunction, drifting and flaring of the teeth, and secondary occlusal trauma like bright collapse. Now stage 1 is initial periodontitis, when you have 1 to 2 mm interproximal clinical attachment loss, less than 15% of bone loss and no tooth loss. While stage 2, you have moderate periodontitis, 3 to 4 mm of the clinical attachment loss, 15 to 33% of the bone loss limited to coronal third of the tooth, but no tooth loss. Stage 3 is severe periodontitis with potential for additional tooth loss, 5 mm or above clinical attachment loss, extending to middle third of the root and beyond, and the tooth loss 4 or less, tooth are lost. Stage 4 is severe periodontitis with potential for loss of dentition, where you have 5 mm or above interproximal clinical attachment loss, extending to middle third of the root and beyond, and the tooth loss, 5 or more teeth are lost here.
Stage defining severity level, that is based on a 30% threshold. Therefore, assessment of extent after the stage has been determined describes the percentage of teeth at the stage defining severity level and conveys meaningful information to the clinician, as it depicts the percentage of the teeth that are severely affected and may likely require the treatment. As per the extent and distribution, localized periodontitis, less than 30% of teeth with the most severe stage. Generalized periodontitis, when they are more than equal to 30% of teeth with the most severe stage. Molar incisor patterns which are affected. It's very important for you to memorize these tables that I have already just explained you about stage 1, 2, 3 and 4 based on severity, complexity, extent of distribution. That's the staging, and then the periodontal grading that we have. Periodontitis grading aims to indicate the rate of periodontitis progression responsive to standard therapy and the potential impact on the systemic health. Clinician should initially assume grade B disease and seek specific evidence to shift to grade A or C. May revert to a lower level after therapy, unlike staging, if the risk profile of the patient improves significantly. You can see here the primary criteria for the progression. Direct evidence, if you see radiographic bone loss or clinical loss of attachment. Grade A is no loss over 5 years. Grade B, moderate rate, less than 2 mm over 5 years bone loss. Grade C, rapid rate, greater than equal to 2 mm bone loss over 5 years. Indirect evidence, percentage bone loss as per the age, less than 0.25, 0.25 to 1% or greater than 1%. Case phenotype, destructive level is low deposit despite heavy deposits, or destructive level is proportional to amount of deposit, or destructive level is high despite light deposit and good oral hygiene. The grade modifiers are the risk factors we have, like smoking, diabetic, non-smoker, less than 10 cigarettes per day or greater than 10 cigarettes per day. While in diabetes, you can have the grade 1, normoglycemic, no diagnosis of diabetes, or if you have the grade B, you will have HbA1c level less than 7% in patient with diabetes, but in grade 3 you will have HbA1c greater than equal to 7% in the patients with the diabetes. Diet evidence, whenever available, diet evidence should be used for grading the periodontal disease. Diet evidence means evaluating the progression of periodontal in a patient over a 5-year period by calculating, measuring the radiographic bone loss or clinical loss of attachment that have occurred in the last 5 years. So if it is 0, that means slow progression rate, grade A. 0 to 2, moderate progression, grade B. If 2 mm or above, rapid progression rate, grade C. While the indirect evidence is to calculate percentage bone loss from the radiographs and divide by age. Another method is to evaluate a relation between destruction level and the oral hygiene. So percentage bone loss over age divided. So 50% loss in 50 years, grade A less than 0.25, grade B 0.25 to 1, and grade C is greater than 1. The grade modifier definitely can be the risk factor like smoking, poor glycemic control that are considered in all cases when modify the rate of progression, highlight the need for careful medical history and frequent updates. So periodontitis can be definitely a manifestation of systemic disease like genetic disorder, Down syndrome, LAD, Papillon-Lefevre syndrome, Shiriaki-Higashi syndrome, histiocytosis, glycogen storage disorder, Cohen syndrome, Ehlers-Danlos, and hypophosphatasia. So major effect of this disorder is through the alteration in the host defense mechanism, clearly described for disorders such as neutropenia and leukocyte adhesion disease. Many of these disorders can appear at an early age and may be confused with aggressive form of periodontitis with a rapid attachment loss and potential for early tooth loss. So periodontitis is a manifestation of systemic disease. The diagnosis to be used when systemic conditions is a major predisposing factor and local factors like plaque and calculus are not clearly evident. So peri-implant disease and the conditions